Hi, I'm Ellen Zappo-Sassu, Mayor of the City of Bristol. I'm here tonight to introduce a topic that's very close to the hearts of many in our community, the opioid crisis. Today, we see more people suffering from opioid crisis-related health issues, as well as interactions with the police department than ever before. In the City of Bristol, we have deemed ourselves a recovery-friendly community, and that means a couple of different things. You're going to hear from people from Bristol Health, from Wheeler Clinic, from the Bristol-Burlington Health District, and our Chief of Police on why we are going to work together to solve this community problem. I hope you take the next 30 minutes to understand the topic, listen to the speakers, and find a way that you too can be a part of the solution for the City of Bristol. Thank you.
Hi, my name is Frank Caputo. I'm here to hopefully facilitate this group we have today, comprised of people from many disciplines in the City of Bristol. These are all members of the Opioid Task Force. These are all people that have come together to try to work on what may be perceived as an opioid crisis, and everyone here has the education and expertise to add. Plus, they have another E, which is empathy, and that makes a big difference to the people. I'd like to have the people introduce themselves from right to left, if you can. Courtney?
Courtney Pope, the Director for Behavioral Health Services at Wheeler Clinic here in Bristol.
Brian Gould, Chief of Police, Bristol Police Department.
Andrew Lim, Medical Director for the Bristol Hospital Emergency Room.
Courtney Dollar, I do harm reduction outreach with the Greater Hartford Harm Reduction Coalition.
Brian LaForge, I'm an operations manager with Bristol Hospital Emergency Medical Services.
Lisa Coates, Operations Manager for Bristol Hospital Counseling Center.
Marco Palmieri, Director of Health for the Bristol Burlington Health District.
Okay. Well, I'm going to start with you, Marco, since we have the thoughts. As I mentioned before, by the way, my name is Frank. I work for Wheeler Clinic also, part-time. Anyhow, people are calling this a health crisis, okay? And in response to that, I want to ask you why you consider this to be a health crisis. What does the data say regarding the fact that...
Sure. Well, for one, more than 130 people die each year in the United States from opioid-related overdoses, and hundreds more survive, which for some is just another day to unfortunately experience another overdose. So let's face it, opioid use disorder is a disease that has penetrated deep into the community and extended far beyond the clinic walls. The opioid epidemic has forced public health to shift from our traditional treatment and recovery services to explore causes so deeply rooted in the community that it can only take an entire community to control the disease. So the public is correct. The opioid epidemic is a crisis. Here in Bristol, Connecticut, and in many towns across the United States, opioids have plagued the entire community, challenged our traditional systems, and devastated families. With this, we can call it a crisis. This epidemic has been called the worst drug crisis in American history. Death rates now rival those of AIDS in the 1990s. And in 2017 alone, over 47,000 people died in the United States from opioid-related overdoses. Here in Connecticut, over 1,000 people from 2012 to 2018 died from accidental drug overdoses, and over 14% were Bristol residents. Now, this is very, very alarming because the city of Bristol accounts for only 1.7% of the state's population. Furthermore, in just 6 months, from January 1st to June 30th of 2019, 544 residents from Bristol died from accidental drug overdoses, and 2.4 were from the city. So these are pretty compelling statistics that can explain why it's perceived as a public health crisis.
Yes, a lot of what we try to address is based upon the statistics that Marco makes available to us. We refer to him as data, like in the Star Wars with it. No. Anyhow, thank you very much. Very good. Following that, it'd be nice to perhaps talk about what happens. We're talking about emergency situations now. You know, what happens when you get a call for an opioid overdose that you were speaking about. And I'd like to ask, what the sequence is, what you do with this situation. And I want to ask Brian and Dr. Lim, you want to contribute to that also, whenever you have a chance? What do? You get a call, overdose. What do you do?
Sure. So when EMS is dispatched for an overdose, we respond, and we usually meet PD at the scene already with the patient. They're responsible for being the real first responder. They administer Narcan if it's needed. Narcan is the drug that reverses opiate overdoses. And then when we get there, we determine how much Narcan PD has already given, assess the patient, and determine if more Narcan needs to be given. So oftentimes the amount PD has given is not enough, so we have to establish an IV, give them more Narcan. While that's going on, we're breathing for the patient, because oftentimes they're not breathing. We breathe for the patient, administer more Narcan, and wait for it to kick in, so to speak, wait for it to do its job. And then when the patient wakes up, we ask them, we tell them they should be transported to the hospital for evaluation, for their treatment, and then we let them know that there's other services at the hospital. If they're willing to get help, if they want help, we can help them get that help.
Helen?
So when the patients arrive to the emergency room, we do a full evaluation. And if they have awoken from their acute overdose, oftentimes many of the questions that we'll ask them are if they're interested in detox. And oftentimes when they've experienced a life-threatening event like that, the motivation is high to get help. I think it's pretty evident that they need help and that they were lucky to survive this incident. The first part is, of course, making sure that they're safe because Narcan will wear off. It is a short-term fix to the overdose, so we need to monitor their vital signs, make sure that they don't have any signs of resedation once the Narcan wears off. Of course, we do our best to encourage that patient to seek help and seek detox resources, and we offer them a recovery coach. We actually have a contract to call in a recovery coach 24/7. And we also can quantify their withdrawal symptoms. So if that patient is interested in obtaining medication-assisted therapy, such as Suboxone, we have done the appropriate training with our physician staff and our nursing staff to be able to give that first dose of Suboxone when appropriate, and also measure the withdrawal symptoms. From there, we enroll the services of our crisis counselors as well, who will perform a full evaluation. And if that patient decides that they want to get help, and if they want Suboxone, as I said, we can oftentimes get them feeling better from their withdrawal symptoms by starting the first or second dose, with the goal of a warm handoff to our outpatient partners, such as Wheeler Clinic, where there are providers who can continue that prescription for Suboxone. So the idea is that when we receive a patient in that acute overdose setting, we stabilize them, we get them feeling better, and we try to get them help immediately. In an ideal situation, we would have an appointment for them within 24 hours, and that same recovery coach would be able to transport that patient directly to the next provider who can continue the Suboxone prescription. The follow-up is also key as well. So we have built-in follow-up where that patient would receive a phone call at prescribed intervals, 48 hours out, 1 week out, 2 weeks out, and even a month out, to make sure that they're still on track and make sure that they have the resources necessary to keep on track with their detox and rehab process.
Thanks, Zach. Courtney, that one down here, Courtney Poe. The recovery coach is supplied through Wheeler Clinic, is that correct?
So we have recovery coaches, but the recovery coaches that Dr. Lim is referring to are the ones through CCAR. So those are separate recovery coaches.
Okay. I wasn't sure whether you do the same thing over there. CCAR is very good, by the way. And you're correct, Doc, when people call, I work the access line, which is getting people into detox. And the majority of them, I would tell you, come from hospitals. So they've been cleared, they send material to whatever the facility is, they will call us, and then we will provide transportation from that patient from the hospital to the facility, and when they leave the treatment, unless they leave AMA, we bring them back to where they came from. So, very good, very good. Continuing perhaps with the, what do we do? Maybe not, actually bouncing back a little bit. Chief Gould and Lisa, I want to ask both of you, in any order you'd like, about COBRA. You tell us what COBRA is, and any recent success stories, any outcomes of this that you can think of.
Sure. So COBRA is something that actually kind of stemmed from the Mayor's Opioid Task Force, and it's after one of our meetings, Chief approached me about whether or not the hospital would be interested in joining together to help people divert from arrest to get treatment and come to the emergency room, be medically cleared, and connected with treatment. So a lot of what Dr. Lim was talking about is that ability to come in, participate in the COBRA program, and then refer out for treatment. So there are specific COBRA appointments, and the whole program is really aimed at reducing barriers and giving police an option to divert arrest, because there's a lot of data that has just proven that arrest is not helping. So let's get people who are maybe very highly motivated at that moment into treatment instead of behind bars and in our court system. So we in Bristol, there are similar programs like the HOPE program out in Manchester that have done this. We've expanded it to not only opiates, so we try to include all substances in this program as well. So it's the City of Bristol Recovery Alliance, and we've had great success so far. You want to add something, Chief?
Sure. There's some great things have come out of the Mayor's Opiate Task Force. Clearly, what Marco started off with clearly demonstrates that there is a crisis. And if it weren't for all of us getting together, these great people coming to the table, it's the only way we're going to be able to attack this crisis and hopefully catch up to it and end it, is being partners and working together. So I really thank the people that it's a privilege to be on this committee with these great people trying to come up with some solutions. Marco hit on something else, and from the police department's standpoint, we realized that the traditional approaches weren't working. To possess narcotics is a crime. And in the past, we had always been attacking that with criminal arrests. And we see that that's just not working out. There's an overburden on the court system, and the prison system and such. And, this is an illness, and we recognize that. So we've had to kind of change the way we were doing business. So our police department has come up with a multi-faceted approach to address this issue. And one of the ways we're doing it is through educational programs. We're in the different schools providing education. We held an event the other night down at the Bristol Public Library to discuss the drug awareness, to try to educate our youth. I do believe that that's going to be the solution, is we need to break the cycle. And so by getting to our youth and really getting them to understand what's going on, I'm hoping that maybe there we can at least break the cycle. You've heard people talking about Narcan. All our officers as first responders do have Narcan so that they respond to these situations. And as was already spoken, we're able to administer Narcan, which has saved countless lives. It's a great thing to have. We also have disposal. Many people that I talked to in the community were wondering where they should dispose medication rather than keeping it in their medicine cabinets. We don't want it to be flushed down the toilet. We don't want it in our water systems. So the police department put in a medical disposal box. It's in the front lobby of the police department, 24 hours a day, 7 days a week. You can come on down to the police department and dispose your medication, all anonymous. It's a great resource to have. We're still hitting it on the criminal side. We have a local narcotics enforcement team, and we also have officers assigned to the DEA, which is hitting it on the federal level. We're really focusing on the people who are distributing the poison to our community. So that's where our focus is for the criminal side. And this latest one is the diversionary program, is this COBRA initiative. And I won't go more into that because Lisa did a great job of explaining it, but it just gives our officers another tool in their toolbox to address this. And in the past, without having an option like this, they were limited on what they could and couldn't do. So it just gives them this opportunity to go ahead and exercise their discretion and get the people the help that they need. So we do have a couple of success stories. I think, Lisa, you have a great success story that you want to talk about real quick?
Sure. One of my, I think, my favorite stories is that this police were called to a domestic, and this young gentleman was fighting with his aunt and was facing arrest because he was under the influence and was acting out towards his aunt. And the police arrived and offered him the option of treatment or arrest. He chose treatment. He came to our emergency room. Dr. Lim and his staff evaluated the patient, gave him options. He chose to be inducted in Suboxone that day. And the next day, we referred him through a COBRA appointment to Wheeler Clinic. He went to that appointment. And through follow-up phone calls, I've been able to speak to him, and he's still sober and doing really well and engaged in treatment. So in a matter of 18 hours, this young man's life was dramatically changed, and he has the resources needed to recover. To me, it gives me goosebumps just to think about everyone at this table working so hard and to get people the help they need, to get them out of jail, to reconnect with the people that they love in their life. It's a powerful thing. So it's very exciting.
Thank you very much. Courtney Pope, a lot of people are referred to Wheeler Clinic, and I know you have a facility here in Bristol as a complete health facility. What are some of the things that you would do? A person comes there, they've gone through, let's say they've gone through a detox, they want to get into it, and they are referred to an intensive outpatient program. That part of what you do?
So when somebody is referred to Wheeler for services, what happens is they'll come in through open access, so they'll do an intake, and that happens Monday through Friday from 10 to 3 p.m. And they'll come in, they'll be assessed. The clinician will assess for level of care, so depending on what they may need, intensive outpatient, some of them just go into regular outpatient. Some people do just regular individuals. And then from there, depending on what the need is, they might get referred to primary care or Suboxone. So we have the expectation that with our Suboxone or Vivitrol evals, they'll be done within 24 to 48 hours of them coming in for their appointment. For COBRA, it's a little different because what happens is they'll go to the hospital to be assessed, and then typically crisis will call either myself or the MAT nurse, depending on who's available at that time, and we will get those appointments scheduled for typically the same day, but we're shooting for within 24 hours of the phone call happening. For that to happen, and then they get engaged in services, and then hopefully from there everything kind of just sticks.
And if the person goes through the IOP or maybe doesn't complete it, would you be able to refer them to an inpatient rehab or residential program?
Yep, so that's where our peer recovery specialists come in. We have 2 of them. We have one that's associated with the How Can We Help grant that the city of Bristol was granted, and she can help any opioid user, any person that has had an opioid use history, which is nice because it allows for a lot of flexibility within that. And then we also have another peer recovery specialist that helps specifically the clients that we have that are receiving medication-assisted treatment services. So either one of them can help call. So they set up transportation. They help try to facilitate the clients going inpatient or to detox, whatever is appropriate at that time.
Good. So it's not just the case where you're detox, you can come home, you're fine. It doesn't work that way, unfortunately. So there has to be a lot of follow-up, and it has to be something that the patient wants to do. We're looking a little bit maybe on preventive medicine or whatever it is. Courtney next to me, okay. Tell us what you do as far as harm reduction or making facilities available, whatever the case is.
So I work out in the community. I meet with people that are currently using substances and provide things like needle exchange, safer inhalation kits, Narcan and Narcan training. And a lot of the times these are folks that it's hard for them to engage with services, or they might not know how to engage with services. So I've often been referring to, Wheeler's peer recovery coach. I actually just brought an individual into the hospital today for detox, which was really great because he's been automatically set up with a CCAR recovery coach to follow him.
Good, good. No, that's kind of like a little preventive medicine, whatever the case would be. I have to mention also that people here have been talking about, what, when, where, but we also look at the why behind this too, because addiction is a behavioral health illness, diagnosis, and unfortunately some people don't believe that, and that's where you get this stigma of all drug users are all terrible people. They're all number one, they're all kids, they're a member of an ethnic group, but no, it's not true. That's not true. It goes across the board from young children to adults. I had clients in their 60s. And one of the problems is not just the heroin, unfortunately, it's also opioids, medications. Some people feel that, well, I'm not a drug addict because I'm taking these opioid medication. It's a medication. That doesn't work that way either. If you become addicted to it, you're still addicted to it. Is there anything else that somebody might want to?
Can I speak to that a little bit?
You
Frank?
most
I feel
certainly can.
So Dr. Lim and I went out and we helped train some of the police staff on the police department on the COBRA initiative. And in talking to them, I think the biggest feedback we got was that this disease has not discriminated, that it's affecting everyone. And people say, well, not me, not my family, not in my neighborhood. And really it's impacting every single person, and from first responders to the police to hospital staff to everyone, we can really speak to the fact that it's impacting every single person, and it's really sad to watch. So it's really great to be part of a team like this of professionals who from so many different areas are willing to work together and just fight this together because it's overwhelming.
Frank, if you don't mind, I just think it's important that we also address the fact that Bristol is a recovery-friendly community, and we truly are. We're not just using the term and the fact that we are designated a recovery-friendly community. We all do reach out to business communities, those engaged not directly in the opioid crisis, so they recognize that folks that are truly suffering from opioid use disorder are folks that look just like you and I, and they should not be exposed to or stigmatized any more so than anyone else would expect a person who is dealing with such traumatic and troubling circumstances. So it's really a testament to all the folks here and everyone in the community, and the mayor especially, who has really been relentless to make sure that we are on task and created a recovery-friendly community network, which is really unique, and I'm proud to say I'm part of it.
Absolutely.
I'd like to add on as well too. Along the same theme, I share the same sentiment that it's an honor to sit on this committee and be part of something this big. From my perspective, at least from the healthcare provider perspective, it's amazing to see where we've been and where we're going. I'd say maybe about 10 years ago, I think providers were very much a part of the problem. I think there wasn't enough knowledge about the dangers of opioid use and chronic opioid use. You had mentioned that there are many different people are affected, and I think the story that we hear too commonly is that a patient may come in with some sort of acute injury, maybe a broken arm or whatnot, and is prescribed narcotics, which is appropriate. But I think unfortunately for some people the narcotic use continues and once it turns into more of a chronic prescription, that's really where the issues occur. And I think now there's a lot more education for providers and doctors about the dangers of opioids. And for many of my patients, they come to the ER with a lot of knowledge that, hey, maybe Tylenol or Motrin, is just as appropriate for pain. Maybe I don't need that opiate. And so there's a lot more careful prescribing that I see from our profession, thankfully. Kind of going back to where we've been, likewise, 10 years ago when a patient would present in overdose, I think a lot of the thought was, well, let's stabilize them, let's discharge them, we'll give them a sheet of referrals, kind of good luck, make some phone calls, good luck to you. And that's really shifted toward and evolved towards, hey, this is our problem. We should really be doing something about it. So we started to give out Narcan kits. We started to talk about, hey, you should really get some help. If anything happens, here's a Narcan kit just in case of emergency, which is kind of evolved into what we're doing now, which I would describe as really wrapping all the kind of bits and pieces and resources that have been available into one complete package where, someone can walk in our door, whether they come from a police referral or from EMS in an acute overdose, or they just come in the door saying, hey, I want help. Or we identify someone who has, an opioid use disorder that they haven't realized, and we're able to kind of bring to the table all the resources that already exist to give that person, that patient, their best shot at recovery.
Very good. Thank you. There's more to it than just in and out type of situation. Yeah. Well, I want to thank everyone here, unless somebody else has something they want to contribute. As Dr. Lim said, and a couple of others, I'm proud to be a part of this task force. Like I say, there are some very intelligent people here. And again, back to the word empathy, that does make a difference if you can understand and kind of feel your pain type of situation. Not sympathy, empathy, it's a difference. So I thank you all for watching us tonight, and have a nice day.
There is not a day that goes by that our Bristol EMS and police department are not responding to overdose calls in every neighborhood, in every corner of our city. So the situation is real.
Opioid use, it's a medical diagnosis. It's a disease, and people need help. Like any other disease, they need medical attention.
This is a crisis that's affecting all families, and we just need to come up with a different way of doing business.
You can't get a job if you are facing an arrest or if you have charges. I mean, that's really hard to find someone who's willing to employ you. And so then we're just kind of perpetuating the cycle. So if we can get them early, then that's wonderful.
The actual function of COBRA is going to be for the police to have discretion to offer the alternative instead of incarceration and going through the legal process, to go to the hospital instead to seek treatment and work with the recovery experts that are in the emergency department to create a plan.
We've done specific training with our doctors and our nurses about how to quantify the withdrawal symptoms. And we know specifically what kind of blood work testing and diagnostic testing we need to perform so that there can be a warm handoff to the outpatient providers who will continue the medication-assisted therapies such as Suboxone.
We want to connect them right away to services. So we've gone to community agencies and asked for specific COBRA appointments. The crisis clinician will make that appointment for them. They'll be scheduled, and the recovery coach can even drive them to that appointment. So really trying to reduce barriers.
We're going to have a safe zone here at the Bristol Police Department, and if somebody feels that they would like some assistance, they can walk into the Bristol Police Department and they can speak with an officer, and he or she will be able to help them and will be able to facilitate getting them into the COBRA program.
We believe that the COBRA Alliance is going to be a frontline strategy for people to get the help they need, start recovery, and actually stay in recovery, which will result in a healthier community.
Bristol Hospital ER can be the front door to the recovery process. We now have the ability to really wrap every resource in the community around that patient who needs the help.
The police department wants to do everything we can to help these devastating losses that we're dealing with.
My hopes for this are that we get to reduce deaths by overdose in our city. I mean, we really are losing people at dramatic rates, and we really need to do something dramatically different to help fight this.